is also a rice eater, right? Raw rice eater. I don't know. Rice helps our dentist in this way. Okay, the patient came. She was an old patient. We did lot of root canal fillings. When the lower anteriors, we did root canals, and this is the status of root canal. No, 4 years back, right? I don't know. Everything is broken. The patients are very much maintaining. They are taking care. Food, diet, lifestyle, sleep, exercise, brushing. Then you can do saving dentistry. And we did one lower implant also. Where is the lower operation? See, this is a 3/6 implant. Patient didn't come for any review, any checkup. Now it is mobile and it is totally coming out. The reason may be attrition, teeth caries breakdown, VD reducing. This is getting an eye point. At the time we used to do zirconia crowns. So if zirconia is not going to wear, all the forces will be going into the implant. Nowadays we are not at all doing any zirconia crowns. Now patient himself is asked, I want to end this. Like a mega serial it is happening. There are so many patients, once we tell them full mouth option, they will be very happy. They won't tell any, actually they will feel very happy once you tell no, you have to remove all the tooth. Because they don't want that tooth, even though 2 or 3 are good. They want to remove this and get it settled at one time. Okay. This view it gives a better view. Here root canal, surgeon caries. Of course we can try to save all the tooth, but practically she is very young, below 30 maybe. Okay. Now we are going for a full mouth option for this, not full mouth option, only lower. Upper is quite okay. Opposing dentition, natural tooth. So definitely we should not compromise on the number of implants. Place more number of implants. That is one reason, and she is very young, next 30 to 40, unless some COVID comes. Okay. So multiple root canal teeth. I plan for 8 implants. Okay. So the plan is very simple. This side 4, this side 4. Right? The exactly midline 1 you have to place. Not in the central. If you place central, they will be very close to each other. Lateral. Okay? Lateral to lateral. And distal most implant definitely in the distal root of molar. Here, this is canine, this is first molar, second molar, this is molar. Molar area we cannot place implant, already bone failure is there. So beyond that, in the 7th region, you have to place one. Okay, just we are fixing some location, that's it. Here, the distal root one, you can place. So you have to fill in between. The first premolar is a key area. Upper maxilla, second premolar is a key area. Lower jaw, first premolar is a key area. Why first premolar? Because in the second premolar you have got the metal foramen. So the safe option is the first premolar. Is it first premolar? Yes, first premolar. This is maybe the metal foramen. So lateral incisor first premolar, lateral incisor first premolar, molar order, distal root here, second molar order. Okay. So totally 6 implants.
Actually, between the two, that is the interdental space is being utilized, right, sir?
No. Not exact. Not exact. Just tentatively we have determined lateral incisor.
So we can place it directly in the socket also, or rather we can take the interdental space also.
Yes. I am not very accurate with this diagram. Just So instead of 6 implant, it is better to place 1 or 2 more implant. That to place. So that is in between these two, right? In the second premolar, the metal foramen is there. That is where using a 5.5 basal you can place.
7 areas.
Yeah, 7 area you can place one more. Okay. Here you can place a short but wide basal you can place. Avoid placing here because already you are placing one implant in lateral, one implant in premolar. If you put it in canine, they may be very much close to each other. Even this 6 implant is enough, but just adding 2 more, considering the age and considering the upper jaw, is a natural growth. Okay, so tentative plan. Even in the tentative plan, if you see here the bone density is very poor, and some 8 is present. Okay, of course this is not a problem, but the bone quality is a little bit poor. If you are placing implant here, you can shift this implant to here, because this implant may get each other. So place one implant here and one implant here. We will see. Or we will leave it and we will place one implant in the second premolar. Second premolars are very much ideal for 5.5 minutes. This is a 3D reformatted view. This gives you a wonderful idea about the mandible. See the mental foramen below the second premolar, and here below the second premolar, the wisdom tooth, and see the thin alveolar bone. Okay, see the thin alveolar bone. We have to do some kind of alveolar plastic to remove this bone, because this thin bone definitely is going to resorb after 3 months or 6 months or 1 year. Our implant neck will get exposed. So remove all this, do nice alveolar plastic, and the tooth is also very small. If we extract, just place the implant, we cannot give you a good process. Process needs some kind of thickness. Okay. So extraction is alveolar plastic. So for alveolar plastic, we can use 2 techniques. One is ronger. A good ronger, double action ronger, not the single link ronger, double action. The most important instrument we need during full mouth rehabilitation is this one. Okay. Of course, you can use a burr also, alveolar burr, TC round burr, thick round burr. Used for lab purpose, you can buy fresh new or autoclave and you can use it.
Can you just tell the code number, sir, the bar?
Huh?
What TC?
I don't know, I will show. Compared to burr, ronger is neat, bone dust bone. But if the bone is very much thick, then you have to use the burr. Good ronger you can get from SK Surgicals. Pune. This is the one they are giving the tags, ortho ministers, they are very famous for that. You can get from. Good ronger is difficult to get. You have to take the ronger and try to cut your nail tip, not the entire nail. Okay, it should. Like a nail cutter. It is basically a nail cutter, that's it. If the ronger is not cutting your nail, then it is poor. Okay. Even when we are using for this surgery, some rongers were not good, so I asked another ronger. They become blunt. So what we do is we send to the company again, they may sharpen and they may give us some minimal fee, 1,000 more. Otherwise, you have to use the burr. But when you are using the burr, you should be careful not to damage the flap, tissue, tongue. Lot of bone dust will come, you have to irrigate. The assistant should wear an apron, otherwise everything will become messy. But it finishes faster. But we will do burr with this. So now we will see the cross section. This is exactly in the midline. Not in the central, not in the lateral, exactly in the midline. You can see 2. So this is the lingual side. Right, okay. This is the buccal side, this is the lingual side. So lingual is more vascular. From the vessels are coming. They are going here. And they are making some grooves and they are coming out here. So these are you can see the foramens, lingual foramens. Sometimes even accessory foramens also. Okay. So when you are drilling, just territory drill, and you go out. Okay. So this is lingual perforation. So these vessels, if you damage them, hematoma will form. Okay. This is the tongue, right? The tongue may rise, respiratory issues. There are about 4 to 5 deaths documented till now in literature. So the only high risk complication in implantology is the lingual area of canine to canine. Lingual area of the canine to canine. So whenever I tell this, immediately we get depressed, some fear comes, but it is not like that. It's very easy to avoid this. This complication happened for us once. Okay, immediately the patient got a huge hematoma, the tongue raised, but luckily nothing happened. So the most important part, complicated part, which can life threatening part is the between canine to canine, lingual side. Lingual side, your drill should not go. Lingually, perforation should not happen. How to do that? So when you drill, you have to feel it. Suddenly it will feel the resistance here. Okay? You will feel something resistance here. You should not do the same in upper anterior. Oh, I should feel the drop. You should not feel that drop in canine to canine or even premolar to premolar. In molar region, you can feel the drop. There is a separate technique called lingual cortical engagement, but not in the anterior, canine to canine or lower premolar to premolar. It is highly vascular area.